The broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to the Hermes educational series. And I will say that we are ready to go, but we're going to give just a couple more minutes for people to join who might be struggling with the change in software or whatever. Thank you for attending, and in just a couple of minutes, we'll begin with the presentation.
Yes, hello, welcome again. My name is Marcus Diemling. I'm working for Hermes Medical Solutions, and it's a pleasure for me to welcome you to the 5th event in our educational series that we have started before the summer. Well, we are well back after the summer break. We're full with energy. We are full with good ideas. Today it's my pleasure to announce Antti Solberg talking about the concept of voxel-based dosimetry. We have a next session planned in 2 weeks from today, a little bit less. It's on a Wednesday as usual, about rhinogram processing. So some small advertisement for that up front. Some technical remarks. Please feel welcome to post all your questions that occur during the talk into the chat. We will record them and we will answer them at the end of the presentation as they occur in the chat. Andy will be there to moderate the questions, and Antti, who is presenting in a couple of seconds from now, will be there to answer all your questions. So please be patient. We will answer them at the end of the talk in the order that the questions appear. Now let me introduce Antti Solberg, professor in Lahti, Finland, medical physicist, has been long time on the side of Hermes Medical Solutions, is the brain behind several software packages in our portfolio, among them the voxel-based dosimetry. And he's the one to know the details, he's the one to know the concepts behind it. And I'm very happy and proud to introduce Antti. Welcome, Antti, and please start the presentation.
Thank you, Marcus. Can you hear me okay?
Yes, I do.
Good. All right. As Marcus said, this is the 5th installment of the Hermes educational series. And I think that this is the 3rd time that we are talking about dosimetry. We had 2 previous talks that laid down some foundations of dosimetry and some basic principles. And today we are going to take a bit deeper look on the voxel-based or voxel-level dosimetry. So thank you for joining. And as Marcus said, that if you have questions, please type them in the chat box, and I will try to answer them at the end of the presentation. And please stay muted and save your questions until the end of the presentation. All right. The overview for today's presentation is this. So even though we already had the 2 previous talks, I will still start with the questions that why we are doing dosimetry. And after that, we will do a short recap of the MIRD-based or MIRD type dosimetry. So maybe that helps you to understand the basics of Voxel-level dosimetry a bit better, because it's quite similar. And we will end this series by talking a bit about the uncertainty analysis, what kind of errors you might expect. This has been a pretty hot topic, especially in the Europe during the last couple of years. So I only have time to scratch the surface, but I still want to say a couple of words about it. But let's start with the question that why we are doing dosimetry. As you might know, as nuclear medicine professionals, the current approach for radionuclide therapies at the moment, it's pretty much like this. For thyroid cancer ablation, you give around 100 millicuries of iodine-131. In case of cancer therapy, when there are metastases, you give a bit more, maybe 200 millicuries. For SIRT, you give 200 millicuries of yttrium, and for dotatate and PSMA treatments, you give 4 cycles, each 200 millicuries. So at the moment, the radionuclide therapy, it's given in the same way as chemotherapy. We are not doing it patient-based. It's not individualized at all. And of course, this is something that we would like to change to make it more individualized. So keeping this in mind, so where we do dosimetry and why we do it. I have been working maybe 15 to 20 years in the nuclear medicine business, and if I don't now consider the Lu-177 treatments, the PSMA and dotatate, there has only been a handful of times when I have really done dosimetry, and it has been in cases where something has gone wrong. Maybe we have given a tracer to a patient that we later found out that she's pregnant. Maybe we gave a wrong tracer to a patient, and we needed to calculate the dose just for the patient records or for the radiation protection officials. Then there are some of us are fortunate, and they have been able to participate on radiopharmaceutical trials, and in those cases we also do dosimetry, because we have to estimate the dose to critical organs and so on. But still, the dosimetry, it's not really in clinical practice if you don't consider the Lu-177 treatments. So what we would like to do is that we would like to use the dosimetry to plan the therapy, do patient-specific treatment based on dose planning, or check the critical organs before administering a new cycle of the therapy, as we do with the Lu-177 DOTA or with the PSMA. We check after each treatment what is the dose, for example, to kidneys, and check can the patient tolerate the new cycle of the therapy. The dosimetry has gained quite a lot of interest lately, and why is that? One reason is the new legislation in Europe. There is a EU directive that says that also the radionuclide therapy, that it should be patient specific, that we should try to design the injected activity based on measurements. And as I also said, the new treatments, the Lu-177 DOTA and PSMA treatments, they are fractionated, so you give them in several cycles, and they require an estimate of the critical organ dose before a new cycle. And also the upcoming alpha treatments, there have been publications that they are also given in several fractions, and we need to do some kind of post therapy dosimetry in order to find out the critical organ dose. And the post-therapy dosimetry, how we do it, we treat the patient with the radiopharmaceutical therapy, and then after the therapy we image the patient maybe 1, 2, 3, 4, 5, or 6 times, and reconstruct the images and do the dose calculation after that. And then based on this dose calculation, we check, for example, the kidney or the bone marrow dose, and check did we go over some dose limits, and is the patient well enough to receive a new cycle of the therapy. Of course, we would like to change this to some kind of dose planning environment. So instead of doing the dosimetry after the treatment, we could give the patient some kind of test dose, maybe 1/10 or 1/20th of the treatment dose, image the patient, and check then, for example, in the kidney area, that how many milligauss per injected megabecquerel, what kind of dose we get, and based on that we could design the injected activity. And what is the reason for that? We are not really doing dose planning at the moment. The explanation to that probably is that it has been really difficult to find the some kind of dose response relationship in nuclear medicine therapies. Even with iodine 131, it has been really difficult to show the some kind of dose response relationship. But of course, some people or many researchers believe that this is part of the explanation for the difficulty of finding this relationship has been the lack of proper dosimetry methods. So we still probably need dosimetry in the future to go from the post therapy dosimetry to dose planning. But that was it for the introduction, and now we will go to the calculation methods, which are the main topic for today. And as I explained to you earlier, I will just shortly recap the MIRD type dosimetry, and then we will dive into the Voxel-level dosimetry. As you might remember from the earlier presentations in this educational series, the absorbed dose is defined as the total absorbed energy divided by the target organ mass. Here we have two source organs which are irradiating this target organ in here, and of course the target organ can also be a source organ, and in many cases the biggest dose to the target it comes from the activity that is already present in the target organ. And the MIRD type approach for the dose calculation, it's a 3-step process. The first step that we have to take is to calculate the number of decays that happen in the source organs. So the more we have decays, the higher the dose to the target organ. In addition to that, we need to determine the amount of energy that is emitted per one decay. And this is quite easy, because when we know the isotope that we are treating the patient, we know how many or what is the electron energy distribution and how many photons and at which energy it emits. So this is information that we get quite easily. But the most difficult part usually is the how to estimate the fraction of the energy that is absorbed to the target organ per decay. And if we multiply the number of decays with the amount of energy emitted per 1 decay and multiply that with the absorbed dose fraction and then divide it with the target organ mass, we will get the absorbed dose. In a way, this is a relatively simple equation. And the MIRD committee has made this even simpler. They have introduced these S factors or dose factors, which are the absorbed dose per 1 decay. So the S factor is defined as energy emitted times the absorbed fraction divided by the target organ mass. And the S factors, they have been tabulated for various source organ and target organ pairs and for various radionuclides. And the S factor tables, they look something like this. You have the source organs listed in here, and then the target organs, and then you have the absorbed dose per decay at different energies. And the dose calculation, it's very simple. You just multiply the S factor with the accumulated activity. And the accumulated activity, it equals the number of decays that happen in the source organ, and you get that by integrating the time activity curve. So in principle, this is pretty simple approach, and you get the S factors using these cool looking phantoms like here. And the S factors are calculated so that you put a known amount of activity inside, for example, the right lung in here, and then you use a Monte Carlo simulator and check what is the absorbed dose to our left kidney or right kidney or liver and so on. And then you can build these huge tables for the S factors. Even though the MIRD method it's very well accepted and widely used, it has its limitations, and even though the phantoms they look really nice, it still the human body doesn't resemble the phantoms very accurately. So because MIRD is based on phantoms, it has quite big limitations in terms of accuracy. And the second limitation is that the MIRD it can only produce average organ doses. And for example, in the neuroendocrine tumors, we know that the dose distribution it's quite non-homogeneous. So the mean absorbed dose, we know that it's not the best predictor of the tumor response or the normal tissue toxicity. And the third limiting factor is that the MIRD doesn't really have a proper lesion dosimetry, and it's quite often the dose to the lesions that we are interested in, especially if we want to do dose planning. We need to know the dose to the lesions very accurately. So even though MIRD is quite good, it's widely accepted, it has its limitations, and we need some kind of more accurate way to calculate the dose. And this leads us to the voxel-based dosimetry. All right, the voxel-based dosimetry, it's in principle it's very similar to the MIRD-based dosimetry. And the biggest differences between the voxel-based dosimetry and the MIRD-based dosimetry is that the time activity curves, they were calculated on organ level in MIRD, and in voxel-based dosimetry, as the name implies, they are calculated for each voxel, and we have a one time activity curve per voxel. We also do the dose calculation on voxel level. It's not based on a table of S factors, but we are really using the patient anatomy in the dose calculation, and the output, instead of having a table of average organ doses, we get the dose map. So we get the dose value for each voxel, and of course that is in many cases it's much more accurate than the average organ dose. So the workflow for the voxel-level dosimetry is as follows. What we need as an input is a set of quantitative SPECT or PET images, reconstructed images at different time points. They have to be quantitative because we have to know the number of decays that happen inside each voxel, and we need to have a time series of them because we have to know the time course of the tracer. So the activity in each voxel, it changes in addition to the physical decay. It also changes due to the biological factors. And in order to know the washout rate and all that, we need to have a time series of SPECT or PET images. The next step is to align the time series of images to a common reference, and after that we can do the time activity curve generation for each voxel, integrate that the time activity curve in order to get the total number of decays, and after that we can do the dose calculation on voxel level. And let's take a look of all these different steps in the dose calculation. The alignment step is probably the most easiest and most well known to most people. And so the matching voxels, when you do time series of images where the time difference between different time points can be days, you can imagine that the matching voxels, they are not spatially aligned. So we need to register the SPECT and PET images to a common reference in order to generate the voxel level time activity curves. There are many different types of registration methods available. You can do manual registration based on landmarks, or then there are these automatic registration methods. Some of them are rigid and some of them are non-rigid. And the rigid means that only translations and rotations around the X, Y, and Z axis are allowed. And in non-rigid registration methods, you can warp the images to better match each other. And there are some publications that have been done in the voxel level setting, which compare different registration algorithms, and the researchers have found out that the non-rigid methods, they are usually slightly more accurate, especially on small organ or lesion level, but on large organ volume of interest level, the improvements achieved with the non-rigid methods, they are quite minor. And at the moment, the Hermes voxel-level dosimetry package, it's using a rigid registration algorithms or this manual registration. But it's possible that the non-rigid method it's available in the next release. The next step, if you are doing automatic registration, you need to define the cost function that you are using to compare the images. It of course depends on what you are registering. If you are registering images from the same modality, you can use squared difference. And if you are registering CT to NM, you have to use some other cost function. And then you have to choose, are you going to register, if you have acquired PET CT or SPECT CT images, are you going to register CT images or NM images to NM images? And of course, what we are interested in is the NM image time activity curves, and the NM images, they should be aligned as well as possible. But of course, because the washout rate, it differs between different organs, it might be quite difficult in some cases to do NM to NM registration. And in those cases, you might have to go to CT registration. But nevertheless, you use the registration parameters or the deformation map from the CTs to the NM images, and then get the same registration also in the second modality. And we needed to do this registration in order to generate the time activity curves for each voxel. And after we have generated the time activity curves, we have to integrate them. So we have to calculate the area under the time activity curve in order to get the total number of decays that happen inside each voxel. And there are some decisions that we have to make. I will talk about the time activity curve fitting with exponential functions in the next couple of slides. But now I will present the method that the Hermes Voxel-level dosimetry package it's using. So we are integrating the time activity curve based on the trapezoidal rule. So there are a couple of decisions that we have to make. And the first one is the how to treat the time activity curve between the time 0, which is the time of the injection, and T1, which is the time of the first scan. So we have to decide, are we going to extrapolate the time activity curve, for example, based on the physical decay, or are we going to assume linear uptake from time 0 to T1, or are we going to assume equal uptake at time 0 and T1? And at the moment, the Hermes voxel dosimetry package is extrapolating based on the physical decay of the tracer. The next decision that we have to make is to how to treat the endpoint, the time from T4, which is the last time point in here, to the infinity, how we are going to treat this part of the time activity curve. And we have a couple of different options. We could, for example, fit the last 2 time points with the mono exponential function and take the effective half-life and then integrate that curve in order to get the number of decays that are happening after the time point T4. Or we could assume that after the T4 there is only physical decay. And the Hermes package at the moment, it's fitting the last 2 time points with the mono exponential function, and it's extracting the effective half-life, and then we integrate that. So from the time 0 to T1, we extrapolate using the physical half-life, then do the trapezoidal rule, integration in here, and after the last time point, we do the fit for the last 2 time points. But of course, what you could do is that you could fit the time activity curve with some exponential function and integrate the exponential function analytically, and then you don't have to worry about the how you are going to treat the this part or this part. And there are some publications about this, and it's even though it's as a mathematical problem, it's quite easy to do the fitting, and voxel level or organ level doesn't really matter. You can use the same algorithms for it. But the problem is the voxel level noise. And in here you see 2 images from this publication of Sarut that was published in Medical Physics in 2017. And this is indium 111 labeled monoclonal antibodies, and the patient was injected with these antibodies, and based on the imaging, they did yttrium therapy on it. And the patient was imaged 6 times. The different time points were registered, and after that, on the left, they used the bi-exponential function fitting to all voxels. And the yellow part in here shows the voxels where the fitting failed. So there is quite a large number of voxels where the fitting approach doesn't work. Then what they did is that instead of fitting with just one exponential function, they fitted every voxel. So the time activity curve for every voxel, they fitted those with the 4 different exponential functions, and selected the best fit based on the Akaike criterion, and they got this image. So in these cases, of course, there are still quite a lot of failed time activity curve fits, but still this approach works much better than the approach on the left. And this was also the reason why in the first version of the Hermes Voxel-level dosimetry, we have chosen the approach to use the trapezoidal integration, because in that case we always get some kind of robust value for the time activity curve integral. But it's quite likely, due to the customer requests, that in the next version of the dosimetry package, that we have to make fitting functions available for the customers. All right, now we have registered the images, we have generated the time activity curves, we have integrated them, and so we know how many decays happen inside each voxel. And the next step is to do the actual dose calculation. In the MIRD approach, we did this by using the S values, using the table search. But if we want to do this in Voxel-level, we have to have different kind of methods. So there are different methods available. The easiest one is the local deposition model. So we assume that all the energy that is generated is absorbed in the same voxel where the energy was released. Doesn't matter is it photon or electron, the energy is assumed absorbed in the same voxel where it was released. This is of course very simple and fast to implement and perform, but it doesn't take into account the cross irradiation between voxels. The second approach is to use dose point kernels. So the dose point kernel, this is a 2D presentation of it. It's a kernel which is generated so that we put this radioactive source inside water, and then we use a Monte Carlo simulator to calculate how much dose does the point source generate around it. And then when we have the dose point kernels ready, they of course they depend on what isotope we have. We can convolve the image, the accumulated activity image with this dose point kernel, and we get our voxel level dose map. Again, this is relatively easy and relatively fast to do, but it cannot take the tissue homogeneities into account. So, for example, in human body there is soft tissue which is very much water-like. Then there is lung tissue, there is bone tissue, and this dose point kernel usually assumes that all the material is water. So we cannot take the bone and the lung, for example, into account. But this is one of the most widely used methods, mainly because it's fast and easy to do. The S-voxel method, it's very similar to the dose point kernel method. So this is resembles the normal MIRD method quite a lot. But instead of having the S factors on organ level, we have the S factors on voxel level. So we generate this target and source voxel pairs, and again use Monte Carlo to generate these S-voxel tables, and then we can convolve the cumulative activity with the voxel-level S factors. Again, this is fast, but it has the same problems as the dose point kernel method. It cannot take the tissue inhomogeneities into account. The fourth method is the most accurate method available today. So we use the Monte Carlo simulator to simulate the photon and particle transport. And how does that work? I have an image about that in here. So we have the accumulated activity, the number of decays. We have a certain number of photons and electrons that are emitted from each voxel, and then we will select a voxel, and then we will sample the electron and photon spectrum and pick an electron or photon and their energy, again based on how many decays we have happening inside each voxel. Then we will draw the direction of the electron and photon, and this is usually drawn from a uniform distribution, so it doesn't really matter in what direction the electron or photon goes. And then we will calculate the free path for the photon until it has its next interaction. And at the interaction site, if the particle is a photon, we sample, is the interaction, is it the photoelectric absorption, is it the Compton scatter or a coherent scatter? And if it's a photoelectric absorption, then all energy is absorbed in this voxel in here. If it's a Compton scatter, then part of the energy is absorbed, and the photon changes its direction. We calculate the new free path and follow this loop as long as the photon lives. And if the photon is if the interaction type is a coherent scatter, then we just change the direction of the photon and non-energy is released. And we do this for a certain number of electrons and photons, and at the end we get the dose map. The good thing about this is that we take all the physical properties of the electrons and photons into account. We take the patient anatomy into account, because the free parts and the interaction types and probabilities and all that, they depend on the tissue composition which we get from the CT scan. The downfall for this is the speed, because the Monte Carlo simulation it's very time consuming, especially the electron part. The reason for that is that for photons, the free path it's measured in centimeters. So the the photon can take pretty big jumps inside the CT image, but the electron free range is in level of micrometers. So it travels very slowly, and tracking the electron path is really time consuming. So what we have done in the Hermes package is that we simulate the photons using a full Monte Carlo simulation. We have made a very fast Monte Carlo simulation for photons that we can use in both reconstruction and in the dose calculation. And for the electrons, we assume that they are assume the local deposition for them. So if an electron is emitted, the electron releases its energy in the same voxel where it was generated. And the common question about this is how accurate it really is. And in here, the Hermes Voxel-level dosimetry application, it has 7 different isotopes, all listed in here. And we have compared the Hermes Monte Carlo simulator against the Penelope Monte Carlo simulator, and these are dose volume histograms for the different isotopes. The Hermes one is the red one, and the Penelope, which is the full Monte Carlo simulator, is the blue one. And we can see that with indium, technetium, both iodine isotopes, and also with lutetium, these dose volume histograms, they look quite similar. But for gallium-68 and yttrium-90, there is a bigger difference, and this is due to the higher energy of the yttrium electrons, so they can escape from the voxel where they were generated, and also the gallium-68, the positron energy, it's quite big, so the positrons they can escape the voxel where they were generated. When looking at these images, it's still important to remember that these were generated with mathematical phantoms, assuming that there is no partial volume effect or anything like that, that there is a perfect resolution. And that is of course not the case when you use SPECT or PET as PET images as a starting point for the dose calculation. Especially with the gallium and yttrium, the starting images, they are already blurred, so you can think that the reconstructed images that they already include the electron dose blurring. And if we add the blurring generated with the Monte Carlo simulator on top of that, it's possible that we blur the images a bit too much. But it's possible that after a couple of next releases of the Voxel-level dosimetry, the Hermes Voxel-level dosimetry package, that we also have a fast full Monte Carlo simulator for electrons available, but that we still have to wait a bit. And we have also compared this approach against Olinda. As you can see on kidney level in the Lu-177.8 treatments, the correlation is quite good. But if you do the blunt Altman plots, you see that there are some differences in here, even though we use the same VOIs and all that stuff between the two different calculation methods. All right, but that was it for the Voxel-level dosimetry, and I will now very shortly explain some principles of the uncertainty analysis, which has been a hot topic in the European meetings for the maybe last 1 or 2 years. So, as you know, the internal dosimetry, it has many sources of error, and the uncertainty analysis for MIRD type dosimetry, it has been presented for whole body planar imaging and SPECT-CT in these 2 papers, and the latter one is even an EANM guideline from 2018. And the uncertainty analysis, it's based on the law of propagation of uncertainty. And if we think of the equation for the absorbed dose, the MIRD equation, it was the absorbed dose is defined as the cumulative activity times the S factor or our dose distributor algorithm, and assume that the uncertainty in this and this they are not correlated, then we can calculate the fractional uncertainty based on this algorithm. And the Y means the U, it means the variance of dose, of cumulated activity, and of the S factor. And in Voxel-level dosimetry, if you apply Monte Carlo, this uncertainty for each voxel, it's not too difficult to calculate. We can run the Monte Carlo in batch mode and get the standard deviation for each voxel quite easily. But interestingly, the calculation for the voxel-level variance of the cumulated activity, it is not as trivial as it first seems to be. So the cumulated activity for each voxel, it depends on the number of counts in each voxel. It depends on the calibration factor from counts to activity. It depends on the registration algorithm and how we do the curve fitting and curve integration. And the voxel-level variance for the OSEM reconstructed images, it's quite difficult to get. There are publications where people have tried to calculate the based on the projection data, what is the variance in every reconstructed voxel, but there are no good equations available for that. So what we could do is that we could bootstrap the projection data. But in order to do projection data bootstrapping, we would need to have multiple rotations of the target, gated acquisition or least mode acquisition, and this is quite difficult to get from the normal, even the modern cameras. So this is quite difficult to do. It's difficult to calculate the voxel level variance. For the calibration factor, we can define the calibration factor as the number of counts divided by the activity, and we can calculate the uncertainty for it quite easily. The registration accuracy, it's partly part of the time activity curve accuracy, and we can get the accuracy of the fitting algorithms relatively easily, but we still have to accumulate these through the integration procedure and so on. But what I'm trying to say here is that when we combine the uncertainties in 1, 2, 3, and 4, it is not as trivial as it seems. But the Hermes package, it doesn't have this available yet, but this is something that we are working on at the moment, and maybe it's available in some of the future releases. All right. In summary, we discussed why do we need dosimetry. We took a look on the MIRD type dosimetry. We discussed why it's not enough in many cases. We took a deeper look how the voxel-level dosimetry is performed, and we scratched the surface of the uncertainty analysis for voxel-level dosimetry. All right, I thank you all for listening, and if there are any questions, I can try to answer them. Thank you.
I'll give you a second to take a drink or whatever. I know that's usually needed after such a long one.
Yeah.
And we do have 2 questions so far, and I'll ask them of you when you're ready. But thank you for a very nice presentation. I will, before I start the questions, I will of course say it was really nice to hear a tease that there will be a full electron code. And so now that I've finally broken that through, I'm going to start on the alpha emitter one immediately.
Okay.
Yeah. All right. So the first question came from Julia Broche, and it says, Dear Dr. Solberg, could you please comment on the change in organ volume mass when using non-rigid registration methods, since this changes directly influences the absorbed dose?
Yeah, of course, what we are doing the calculation on voxel level, but of course there are also changes in that. I really cannot answer that. I haven't done too much research on the non-rigid algorithms. As I said, the entire Hermes package at the moment it's based on the rigid registration methods, but I do understand the concern, and of course the non-rigid methods, they are good, but the problem with the warping, it can change the results quite a lot, and we have to be really careful when we implement that.
My experience with that is also very similar, and I would say though the problem is that there are multiple methods out there for how they, just like conserving counts or conserving mass, obviously you can still move them around. So it would really depend on what technology they use, as well as, and since we don't use any at this time, it'd be really hard for us to, The next one chronologically actually came in the chat, which is fine. But because of that, I don't know who it came from. And if anyone, their question, if you don't feel like we answered it to the way you wanted to, maybe throw a hand up, and we can unmute you to ask that question, or do a follow-up if needed. So, but I'll move on to the next one chronologically. It was Marcus. Antti, you have shown the map in yellow for all voxels that could not be fitted. Only after offering various fitting methods, the best fit could estimate most of the voxels that could not be fitted. But isn't it an additional benefit that we can at some point exclude all the voxels that could not be fitted well, as most of them seem to be related to movement artifacts, or I would say in the area of very low uptake as well? I'd add that, but do you have a comment toward that one?
Yeah, of course, there are methods how we could treat those situations. For example, try to interpolate from the surrounding voxels or something like that. We probably don't want to leave empty voxels inside the accumulated activity map. We have to fill them in using some method, and maybe picking the effective half-life as an average from the surrounding voxels might be one approach, or to use the physical half-life if that is appropriate.
Mark Baker is asking, hi, apologies if I misunderstood, but would combining the Monte Carlo phantom data with a dose point kernel for positrons give a better DVH agreement than using a local deposition model? And would there be any downsides to this?
Yeah, of course, always the downside in using the dose point kernels is the assumption of the homogeneity of the surrounding tissue, and it can have impact on tissue surfaces. For example, if there is a lesion in the lung, and how to treat that. But I think that at the moment we have shown that especially with the isotopes that have the lower positron or electron energy, the local deposition model, it works quite well. There are also publications, at least one, which shows that the local deposition also works very nicely with yttrium. We haven't done too much work with yttrium dosimetry yet, but I'm quite confident with the method that we have at the moment. But of course, it's possible when the resolution, especially with the PET, modern PET scanners, it gets higher, and you want to do the dose calculation in smaller voxels. It's possible that we get these escaping positrons and escaping electrons that we need to model in a more accurate way. But as I said, I think that the Hermes as a company, we are more interested in the full Monte Carlo modeling than on the more approximate dose point kernel method.
And I'm going to give you just a second if you put your hand up in there if you have a follow up to your questions, but otherwise I'll move on. Looks looks like we're clear. So there's actually a follow-up to this one immediately, so I'll ask it, but give me a pause and I'll do the follow-up. This comes from Martin Tournay, and it says, you compared the Hermes package to other Monte Carlos. Was there a comparison to phantoms or real measurements where the doses could actually be measured in real time? In other words, what is the absolute calibration of the dosimetry? What is our gold standard, I would say?
So our gold standard was the Penelope package. We did the comparison on using the mathematical phantoms. Of course, we have done the same comparison also with the LU 177 spec data coming from patients. We have compared the full Monte Carlo against our simulator, but the results that I showed, those were coming from a XCAT phantom trial. We have also compared our simulator against the TLD thermal luminance dosimetry methods, but it seems to be quite difficult to compare those against the dosimetry methods. And again, what we have done is that on several isotopes we have compared against the Olinda. Of course, Olinda is not the best gold standard available, but still we have done that. So we have done quite a lot of validation work for all the isotopes, and as you probably might know, the Voxel dosimetry package, it's already FDA approved, and it's also CE marked, so it can be used in Europe too.
Very good. I would also add that while I completely and wholeheartedly support the idea that the Penelope package is really a very good gold standard, there are publications out there using Hermes versus implanted TLD strips as another way to do dosimetry inside of phantoms that were more human-like. The results to them came within the error bars of the TLD strips, so we do have a little bit of a physical reality as opposed to just doing software to software. But so this one comes from Remo George, and just want to confirm that the Hermes dosimetry system is FDA approved, and you just verified that, so I'll move on. And then the next one, is there any simplified version coming for Y90 microspheres where we could simplify the voxel-level dosimetry using some reasonable assumptions? LED simple TAC accumulations, and that came from a name which I am going to do horribly on, but let me try. Ismail Jafragoli Rongraz. I apologize right now. I just apologize. But do you have anything in the works for Y90?
Yeah. We have focused on the Y90 reconstruction. We have that available in the Hybrid Recon 3.0 and all the versions after that. And of course, Y90 is one of the isotopes that the Voxel-level dosimetry supports. But Hermes used to have a package for CERT, but I have to confess that because I'm not part of that research, that I really don't know what is the situation of the Hermes CERT package at the moment.
I might speak to that. For that CERT package, we use, as is often published, as a very good, valid option, that we just use local energy deposition assumptions for Y90. And unless you're sampling these on very small scales, in humans, I think you're fine on most available scanners. Maybe in a micro animal scanner, will you run into a problem with that? So, the next question comes from Vivek Mishra, and it says, can you comment on the level of uncertainties in dose calculations with each method?
Yeah, that is is a difficult question. I know that the voxel-level uncertainties that have been published and they are around maybe 1 to 5%, but I think that is too optimistic. I would say that according to the research that we have done with the LU-177, that the accuracy of the Hermes package is around 10%, maybe a bit less. But I think that is still quite good at the moment. For the other methods, it's really difficult to say. It probably depends on the is the tissue background, is it homogeneous or not? But maybe it's best that I don't comment at all.
Okay. That does bring us to the end of the questions. We're also just about at the right time. I might throw one out there, giving anybody who's typing one last one a chance, and just ask on a note, maybe a more philosophical note. As we look at iodine treatment for thyroid, which we've been using as a nuke med for years and years and years. And that one came through when dosimetry really, even on the lowest levels, barely existed, and used crude methods. And the dosimetry has constantly increased in its sophistication. And my question is, the impact of not having dosimetry on iodine did not make it any less of a viable option. But as we go forward and we look at some pharmaceuticals that may not be a home run every time, do you see a purpose for dosimetry being more in correct radiation protection and watching a person's dose lifetime and exposure, or do you feel like the real future in it is personalized medicine, giving the most tolerated dose for that individual? Which do you think, and again philosophically, right, this dosimetry will impact the most, if at all?
Of course, I would like to answer that the some kind of tumor dosimetry is the future for this voxel-level dosimetry, or any dosimetry that would be great. But as I mentioned, the NM community has really struggled with the dose response relationship, and as you said, even with iodine, we haven't been able to find it. Of course, the thyroid cancer, the survival rates and all that, they are really good. So maybe that is quite a difficult starting point for all this dosimetry work. But I would really hope that this dose planning routines, that we could show the tumor responses, and we could really design patient specific treatments. But I think that only time will tell how it will work out.
Fair enough. Well, I ask you the longest question I could think to ask, and no one in that time asked another question. Okay. So I assume that's the end. I will begin by saying thank you very much for a great seminar, and for everyone to attend. As you can see, there is at the bottom of his slide an info at Hermes Medical. If a question occurs to you after the fact, or if you'd like to know more directly about our product or our company, you can send your questions to that email. If you have questions about the educational series, which we will, again, as Marcus has already pointed out, there will be a follow-up one 2 weeks from now, or 13 days from now, so that we can get back on our Wednesday schedule. Please join us for that one. And I thank you again. We will catch you guys hopefully in a week from next Wednesday.